So coming to the ECG changes in acute pericarditis, what are the patients can have the ECG changes? The first is the most common, which is seen during hours to days, is the diffuse concave ST segment. So there will be, if suppose you take this P, this is the Q wave, and the patient will have this type of ST elevations. You can see here, this is a concave type of ST elevation, which is a common thing which is seen here. Whereas MI usually have this type of elevation here, you can see is the convex type, whereas the pericarditis have a concave type of ST segment elevation. Important thing is not only the ST segment elevation, patient usually have the PR segment depression. So we consider the BIS as a baseline, and PR segment is usually is down. That means the patient will have a PR segment depression and Q wave, and then the patient have this. So the PR segment is also somewhat depressed, which is the common association of this. So ST segment and PR segment written, what happened? So this was the initial changes. Then the second stage, what will happen is that this ST segment elevation starts getting down. So it will start decreasing. The ST segment starts getting flattened, and PR segment also return to the baseline. And also there will be T wave flattening. The third phase that is seen within the first week, and then days to week, what you see is there is a followed by there is a T wave inversion. You can see here is this, and there is T wave inversion, which you can see occurs after ST segment normalization. And fourth phase is this week 2 months when there is ECG becomes completely normal, or there can be some persistent T wave inversion. Is the stage 4. So many of times acute pericarditis can be suspected as STEMI because both the ECG looks almost similar. But the important thing to remember here is that in STEMI, there is convex type, as I've said. This is the convex type of the STEMI, and this is concave type in that. And usually the elevation is less than 5 millimeters in pericarditis and more than 5 millimeters in case of myocardial infarction. So other differentiating features between acute pericarditis versus STEMI, as already seen, one is the ST segment elevation amplitude is less than 5 millimeters in acute pericarditis and more than 5 millimeters in STEMI. It is concave smiling pattern as seen in pericarditis and convex shape. And the elevations are usually diffuse. So that means that pericarditis will not localize to any segment. The elevation will be usually seen in all the chest leads as well as the limb leads. Whereas the ST elevations of myostemi usually localize to a single territory. Suppose there is, if anterior wall is involved, the only elevations will be there in V1 to V4. Inferior will be there in lead 2, 3, and AVF. So it localizes to a specific coronary artery territory, and reciprocal ST segment depressions are not seen in pericarditis, which is quite prominent here. Important feature to remember in pericarditis that, as I've already discussed, that there is associated PR segment depression, which is usually absent in patients of STEMI. So another differential diagnosis of pericarditis is the early repolarization. That is the benign early repolarization, which also appears almost similar to this. Important thing is that will show ECGs, that is better. So you can see a patient is benign early repolarization is usually seen in young patients that is less than 50 years of age. They will have what is called as some concave type of ST segment elevation. You can see here there is some concave type of ST segment elevation. So this concave type of ST elevation is resembles to that of pericarditis as well. So how do you differentiate is that in pericarditis, usually there is associated PR segment depression. So that is usually not seen in benign early repolarization. Also, as you can see in the inferior lead at the QRS, there is a J-wave notch. This notching you can see here. So let me just zoom it for you. Uh, so you can see here there is a prominent J notching is there. So that is a classical thing is there. But important thing is how do you differentiate is there is something called as ST segment wide T ratio. So that means the height of ST segment divided by the height of T wave amplitude. If we divide, and if it is less than 0.25, then it is benign early repolarization. And in pericarditis, this is more than 0.5. So basically, I mean to see in that in benign early repolarization, usually the T wave is prominent. As you can see here, T wave is quite prominent when compared to the normals. So prominent T wave will be there. So you can see here, this is a case of a benign early repolarization where you can see is J point, which is also called as fish hook pattern. And you have to remember is this is the ST segment elevation from the baseline. So ST, this is the ST, and this is a T wave height. So ST by T wave, if it is less than 0.25, is goes in favor of benign early repolarization, and more than 0.25. As you can see here, the T wave is not that prominent, and this goes in favor of pericarditis. So this is a classical ECG of acute pericarditis where you can see concave shape ST elevations. There is some PR segment depression. Along with that, also you can see that it is not localized to single territory. You can see V5, V6 having that elevation. Similarly, lead 1, lead 2, lead 3, and lead AVF is also there. And also you can see in that AVR, lead AVR, you will have what is called as PR segment is slightly elevated with ST segment depression is also a feature of acute pericarditis.